Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. It's my great pleasure to welcome to Glenohumeral Gurus podcast Edel Fanning, Dr. Edel Fanning. It's so wonderful to have you here. I've been wanting to connect with you for a couple of years now and reading your work. So great to have you on board. Welcome to today's chat.
Oh, thank you, Margie. And it's so lovely to be here. And likewise, I've been a big fan of your work for so long. And because we're obviously in similar fields, even when I'm at conferences, I get asked so much things about your work. And I was saying when Anne Cools, who was my PhD supervisor from 8 or 9 years ago, I remember being in Ghent with her, and she was like, Margie Olds is just, I think you were just publishing your PhD at the time, and she was saying, how interesting and similar things were and all the great work you were doing. So no, I am absolutely thrilled to be here. So thank you so much for having me.
You're very welcome. It's great to chat. And there's so many similarities, isn't there? As we were just saying offline, I think we're both working in that similar field, trying to answer similar questions. So great to be able to connect with you. Can you share with us your physio journey, your career, how you get to be doing what you're doing now and how that all came about?
Yeah, sure. So I trained in the UK, and my career started in the national healthcare system. So I worked in the national healthcare system for about 8 or 9 years, and I was really fortunate. They have a very good setup, really, to promote extended scope practitioner skills
Mhm.
in the UK, and that their health, in that sense, is really advanced and really forward thinking. So I was fortunate enough to work with some really great shoulder consultants where I developed extended skills like scanning and injecting, and then started seeing a lot of the complex cases, so complex instability, complex pain. And outside of the NHS, I worked part-time and saw a lot of the athletic shoulders, and worked with some of the football clubs and things like that. So yeah, that's where my kind of love of shoulders grew, and learned from some really great people there. And then 10 years ago, I moved back to Ireland and started with a sports surgery clinic in Dublin. And by that stage, I was really ready for a change because I was doing a lot of triaging
Mhm.
and and more the diagnostic side. Although I did have rehab, when I went back to Ireland, it was all rehab, which was fab, exactly what I wanted. And also to kind of pursue research because that was my other a kind of big love even in the NHS. So yeah, so I was fortunate enough to start work there with a super bunch of people. So some really great practitioners that were really at top of their game in terms of ACL and hip rehab and
Mhm.
concussion rehab. And you kind of see those people doing it and you're like, oh, why can't I? So it was it's funny how all of that breeds, if you see somebody else doing it, it really encourages in you and I had some really good mentors. Um and I was lucky when well, I don't know, if, the upper limb side wasn't particularly developed. So I had a whole
Mhm.
blank canvas to develop a whole entire upper limb rehab team, return to sport testing. And at that stage, which we'll probably talk about in a little bit, they're always, when are these ready to go back to play? And the ACLs had these massive battery of testing, 3 hours in the lab. The hip and groin lab was up and running, and the shoulders had nothing. And I was like, well, there isn't anything out there. And I remember interviewing, and they were like, well, what do you send them back to play? And I was listing these things, and they had all this high tech stuff. So yeah, so that's kind of and that my research was purely out of a clinical need. I'm first and
Yeah.
foremost a clinician. Or what do we call them? A practitioner or a practical researcher as such. So, yeah, so it was, all of the research questions. I was really fortunate. I got to choose who my supervisors were, the topics
Mhm.
that I wanted to cover. Um, so it was great to have that, purely
Yeah.
out of a clinical need of because of what I was seeing is where my kind of research came from really and the questions. So yeah, so that's
Which
kind of
is
been
where
the journey.
it's so impactful then, isn't it? Because you are trying to answer then a clinical question with your research, and that's how we could maybe make a difference in this space, isn't it?
Yeah, yeah, for sure. That it was, as I say, purely clinical, as in, I didn't have the answers. I didn't know when these are ready, and there was a huge problem, and still is a huge problem, is in the reoccurrence.
Mm.
It's the young contact athlete.
Yeah.
It's the 14, 15-year-olds that are playing. Depends in Ireland. They're so for the rugby lads, if they're called up into their international level, they could be called up at 15 up to under 18. So it's a
Mm.
huge difference. And then if they start dislocating at 15, we know the reoccurrence rate is incredibly high because a lot of them will have a band catheter pair, obviously, because there's often a lag, isn't there, in the growth plates
Yes.
and things. And then you're starting to think, the reoccurrence rate in the best hands of the surgeons is up to 95% in 4 years. So you've all of these running through in your head and like,
Yeah.
what can we do to reduce the risk of that? And the surgeons are trying to advance all of their surgical techniques. And, I think us as rehabbing them have to be answerable as well, don't we?
Yes, and really trying to
No
move that
misfeeling that you
space
send them
forward.
back and they reoccur. Yeah.
Yes, yes. And I think that was the problem for that's what started my PhD as well. You think you've rehabbed them best you can, and then, 6 months later they knock on your door. And I was like, oh, what did I miss? How could I have made that better?
Yeah.
So trying to choose who might be at high risk and who might not be, that was part of that work as well. But anyway, I wanted to dig into your PhD and about how you think the clinical implications are of this work. Can you just broadly give listeners an overview of your PhD and what you found, what you think is important for clinicians?
Yeah, sure. So we kind of started off with a systematic review, and I did a very broad scoping review at the time. I think we screened about 2,500 articles. So we looked just at the athletic population and what outcomes are being used after shoulder stabilization. So really broad, probably too broad. I think we had to include 62. Oh, good, there was a lot of reading. It took a long time, but it was very much to have a look at what's being used in that post-operative group and what
Mhm.
outcome measures were being used. And we found very little because most of the studies were retrospective. So the quality was quite poor. And then
Yeah.
what was being measured was so diverse. So even things like range of motion, trying to quantify that because they'd have a goniometer, some would have a
Mhm.
goniometer and some would have a different tool, and strength was being measured like from lots of different ways. So it was really hard to get any answer, to actually do any kind of meta-analysis or put anything together. It was
Mhm.
yeah, and that might be in part to how we designed the question, because it was very much designed from a thesis perspective as well, as in
Yes.
like yeah, do you know what's out there, rather
Yes.
than even obviously we developed, so it was a huge broad scoping review, but very difficult to get anything. But also it led into, okay, great, this is where we're at. In this post-operative group. And because I was fortunate enough, I think I was saying to you off air, like we were having over about 400 stabs done a year at the clinic in male
Mhm.
contact collision athletes. The females was much, much lower. So we had this huge cohort to look at. So we had access to
Mhm.
this cohort, and very much rather than just looking at, them in the normative, we wanted to see what were happening in this cohort. But we obviously had to start with our norms first,
Mhm.
and have a look where, first of all, what testing. So, and I was exposed to so much from the lower limb through in
Yeah.
services and different things, some really great people that you could kind of okay, see what's going on there. What did they learn? And across their research at the time, and probably still, is that there was deficits across all strength parameters, from max strength to explosive strength to power. There was deficits across them all throughout the phases. So, and they're quite quantifiable markers and things that we had access to. And so that's probably how it started. And I worked with a really great biomechanist who ended up being a supervisor on my PhD, Kat Daniels. She was fabulous. So, we spend weekends going through all the different
Yes.
tests. And it's interesting because I look at some of your tests, like we did the lateral hops over the hurdle,
Yeah.
and then we had some of them that couldn't do it. And it's because we had to have a battery test, and the quality of what was coming through, because they weren't all rehabbed, obviously, at the
Mm.
clinic. So it was hugely varied. So we needed them, even in all our pilots and our trial, to be able to do the tests at 14
Mm.
and 16 weeks post-surgery, because that's when most of them were going back. Um, so we spent a long time piloting things, all the different, like time to stability, impulse, loads of different variables, what we were reliable
Yes.
on. So yeah, we did about 3 years of piloting.
It's
Tied in at the
incredible.
time. I was doing
Yeah.
the review at the time. So lots of weekends and lots of brainstorming. And then you kind of have to settle on something, because
Hmm.
and you settle on the things that are obviously most reliable and that you've drawn
Yes.
from some of the strength parameters that we'd seen. And then the other big thing was, although I've published around the isokinetic and the performance test, we also looked at joint position sense in open and closed chain
Uh-huh.
positions. So we have a
Yeah.
paper hopefully coming out shortly on that, and then the lower limb jumps as well. So we wanted that we've covered proprioception, we've covered kinetic
Yes.
chain to some degree by looking at a drop jump. And then some of the isokinetic we picked because it was gold standard at the time. So I
Yes.
remember we had a retreat, and Christian Turnberg was over, who does in Oslo, who does a lot of the hip and groin, and he was saying, you can't have it too abstract, because you need something that people can relate to, So it was
Mm.
lots of different thought processes. And but I was so fortunate because I could have brains outside of probably the shoulder world looking
Yeah,
at
which is
it.
incredible to draw from, isn't it? In terms of
Yeah,
how
yeah.
it
So
influences your work.
it is our CMO at the time, Andy Franklin Miller. He had great exposure to these, and he had a lot of big ideas. So he used to put us up in front of all these big researchers and make us, say what we were looking at, which was awful. But also really lucky, because they were like, actually, this worked quite well and this didn't. So and then
Yeah.
having access to Anne as well was incredible. And my other supervisor is the chief medical officer of World Rugby, so Aina Falvey, so he's fab, so he had all of that experience. So um yeah, so it was so that's kind of where the tests had drawn from. And
Yes.
so following on from that, I'll do a quick summary now, not the question you'd asked me. So yeah, so then we had a look at these tests in the uninjured population. So we looked at isokinetic strength, but not just peak torque, because we were
Hmm.
finding that came back very quickly. But then in our manual testing, they were still grossly
Mm.
down in the inner and outer ranges. So we looked at the torque throughout range, and we picked some key points. Based on what we were reliable on, and
Mm.
a few different factors that determined why we chose those variables. And then we looked at some performance tests, so a counter movement jump, a press jump, and a box jump, and picked some of the key variables like jump height,
Mm.
take off peak force, take off eccentric impulse, take off concentric impulse. Again, after a lot of piloting, as in what was the most reliable.
Yeah.
And as well as the proprioceptive, we did some open and closed chained proprioceptive testing,
Mm.
because they're already marked up in the lab. So can the joint repositioning, can they relocate to markers? And then some of the closed chains, so they're in a press up position, lower down to a hurdle, and then they come back up, and can they relocate? So a whole kind
Okay.
of yeah, so more in a closed chain position. So and then some of the lower limb jumps. And what we found, so we kind of got our normative values first,
Yes.
and then went into looking at them in the pathological. So the big question, all of this, is what's happening in the pathological group, but it took forever, obviously, because we had to make sure we were reliable in
Yes.
everything. And it's amazing how And I was chatting to you about this, like even with the state of the art equipment, how much work it goes in to be
Mm,
reliable with
mm,
isokinetic testing. And there's so like, yes, you're constantly having to stay on top of all of that. Otherwise, if you get huge measurement errors, like things like range of motion, we weren't able to be reliable among ourselves. Measured in every single way. And schools
yeah,
had put out a paper that they were reliable in measuring range of motion, but she had done it with a group of students, and I think because we were probably more experienced practitioners, went against us. So we couldn't record range of motion because we had like a 20 degrees error
yeah,
in our total
yeah,
range, which is massive.
yeah,
Um, yeah, and so then we went and had a look at them in our post-aid group and found that there was again what you were seeing anyway, but there was quite big deficits of 4 or 6 months on these performance tests and isokinetic
mm,
variables when a lot of them go back to sport. And then
mm,
finally I had a look at some of the psychological measures. So hopefully she'll have a paper out shortly on that, on the we had a look at the psychological measures at pre-surgery, 4, 6, and 12 months post-surgery, and what's happening, and
wow.
is there any relationship with that and time to return to sport. And
And you
yeah,
measured that, the site measures you measured with the Cersei, or you measured them with something else? That's how you,
Yeah.
yeah.
Yes, I see, and self-motivation. So
Okay.
there was one of the papers, Sonison, I think it was, had done it in the ACL. And at the time I'd reached out to Claire Adderhern, and she was saying they had found self-motivation was actually quite a prognostic factor as well.
Yes.
So we looked at self-motivation, but actually in our study they were all highly self-motivated, all up at 9 out of 10 on the kind of four
Yeah,
self-motivation.
right.
So probably because of who we were seeing, that wasn't a factor.
Mm,
Just probably in the design, because they were all athletes wanting to go back to sports, so they're all highly
mm,
motivated.
mm.
Um, so yeah, that's probably it in a little bit of a whirlwind,
It's an
but
enormous body of work, isn't it? And it's
yeah,
exciting that there's still more
still very
papers
much in
to
the
come.
infancy and so many other things to look at. But
Yeah,
then we had COVID in there as well, which was horrendous because the hospital closed for a period of time, and
yeah,
anyone that had only tested at one period in time was then excluded, and then things like it's getting the buy-in with the surgeons, and that les like so there was a which all affects recruitment rate and stuff, doesn't
yes,
it?
exactly. Oh, you've done an amazing work, and I'm looking forward to reading those papers that are yet to come. That's exciting.
Yeah, it's getting time, isn't it? To write and
Yes, yes, isn't it? Um, so I specifically wanted to ask you about these measuring force in not so much in mid-range, because I agree clinically I often don't see a deficit there, but in the outer and inner ranges of movement. I don't have access to an isokinetic dynamometer in my clinic, and so I use a handheld dynamometer, but we'll look then at inner range, particularly inner range external rotation in 90 and in neutral if I need to. What are your thoughts around that? Is that okay for me to do that with my handheld dynamometer? Do you think that's going to be different than the work you showed with the isokinetic work?
Yeah, and as I said, I always say this. I would, because we're doing research, and I think that's really important. Obviously, because it has access to that equipment,
Yes.
you're going to use gold standard just because you're going to. All I wanted to see is the depth, because we didn't know, there wasn't much out there in this post-operative group, as I
Mm,
said. So it was more so we got gold standard here. Let's look and see what's there, and
yeah.
then in time, hopefully, make it more field appropriate.
Mm,
But it was very much as in, let's just see what's out there, use gold standard obviously at the start and see if there is deficits. So no, when we know the handheld anemometer, there's lots of studies out there showing that it can be reliable. And as I was saying before, I think the big thing is, whatever your testing is, pick it and just make sure you're reliable at it. And
yeah.
then, and
Yeah.
then, of course, you don't. And even with the isokinetic test, a lot of the time, unless you're working with them, it's so fortunate that I can tell the biomechanist what I want and they pull it out for me. They could
Yes.
put GUI codes in, that made it. I always say they're the brains behind it. So I think the big key thing is that we know there's some deficit in rotational torque, don't we?
Mm,
And even things like the like Ben's work on the force plates, my understanding anyway from his papers and from chatting with him is very much, because of, as a correlation with the handheld dynamometer. So I don't think you need 50
yeah.
million tests. I think you keep it really simple, and if you're doing it well, that's much more than what we used to be doing. And you've
Yes.
got something to be answerable to. And
Yes.
yeah, and I think because I often get asked in team settings, I always say, like, pick two people to do the testing. Obviously, with the handheld dynamometer, the key is often being stronger than the person you're testing, isn't
Yes.
it? And that's
Yes.
positional wise as well. In supine, you generally are. So it depends on the position, but I'm like, let the same people test all the time if you're in a team
Mm,
setting or some of those larger teams, and then they get really familiar and
yeah.
just check reliability, because I can tell you there's huge variances. I'm sure your measurement of error can sometimes be much larger than you think, and that is even with the isokinetic machine. We have to be really on it in terms of ensuring. And as I said, we're fortunate because the biomechanists,
Mm,
they do a lot of even within your force plate stuff. So
mm,
I think that's the big key thing. Whatever you do it, and you'll know your numbers then. Like,
yeah.
I know my numbers for the Isaac Kinetic machine because I use it all the time. But whatever tool you use, it's interesting. And I don't know if you feel this way, but then you sometimes see how. So say the types of tests I use, or the type of tests you use, you sometimes program to because you're going to be testing for those. So I think your rehab, and even I see
Yes.
Ben's rehab sometimes, and he's looking at deceleration stuff out here because he's obviously
Testing out there.
testing out there. Yeah. And then I do a lot of quick eccentric deceleration stuff, or like some of my press jumps on my power stuff. I'll do a lot of power with the prowler, or lots of variations because I'm testing there.
Yeah.
And I don't know, is that a good or a bad thing? And obviously it's so chaotic, all of those environments, but I'm sure it leaves a bias into how we react.
Isn't it?
It
And it's
must
so
do.
interesting because then you end up training for the test, don't you? And you're probably
Yeah.
leaving a gap in some of
Yeah.
that space because you're not testing. So, because I mean, I think some of the data that you've managed to pull out from these force plates is amazing, isn't it? But one of my concerns is that it's all in that flexed at 90, and it gives us such enormous detail about the muscle capacity and all those metrics. But what about out here where my athletes dislocate again? Do you know? What are your thoughts around that? What do you think?
Yeah. No, and that's a really good question. And people always kind of ask me that. And I was saying when I started out on this, I wasn't probably trying to be particularly, reproducing functional tests. I really struggled with the
Mhm.
functional tests because even some of the field tests, I'm like, okay, if they don't score well on the Y balance test, or even the closed kinetic chain one, I always forget that big long name. But if they don't score well on that, I'm like, what does that mean to me? What can I do? What can I
Yeah.
train off that? So I found it really difficult. But that, and that might be just me, but I found it really difficult. Um, and yeah, so that was that, I certainly I didn't think, oh, this is going to be, I'm not trying to, I don't know how you could mimic function in contact athletes because there's
Mm,
so many different, variables involved. So and again, leaning into the lower limb, which literature, we knew things like, um, that the reactive strength was down, and
yeah.
that looked like that might be more prognostic than a max strength. So I was kind of leaning into that a little bit. But then I was also very conscious, and that's why we did a number of tests, and our rotational strength is purposely out on in this plane,
Yes.
and then they don't correlate. So, they could be
Which is
testing right.
fascinating, isn't it? I was
Yeah.
reading through your work again this morning, and I
Yeah.
mean, it just shows that they're different constructs, aren't they? You know,
They
the
are.
strength and
Yeah.
all those metrics you have here are different than that
Hmm.
rotational strength that you
Hmm.
have there, and so
Hmm.
people probably need to test both, when they put together the test battery. That this is another thing I want to ask you. So particularly in my practice based in New Zealand, we see lots of contact collision athletes. And so my test battery for them is different than my test battery for a tennis player,
Yeah, of
different
course.
for a javelin thrower.
Absolutely. Yeah.
What are your
Yeah.
thoughts around that?
Oh, 100% agree. Yeah. And bearing in mind I see a lot of contact athletes because I was saying in
Yes.
Ireland, the big sports are rugby, football, and hurling. And absolutely, I think, and I would also add something into there is the hypermobile contact shoulder.
Yeah,
Um, yeah, they are a nightmare. And I don't know the answer yet there in terms of what I should be looking at or not looking at. And
yeah.
even coming 8 or 9 years into testing now, it's probably time that you'll kind of some parameters were useful and more useful. There was correlation between some that would start to pull out a little bit.
Mm,
In terms of going forward and redesigning. But it's yeah, no, I don't think what I'm finding with the hypermobile, and we do get them, these can be
yeah,
international rugby players that are
yeah,
hypermobile, and I deny
yeah.
on the basis, or they can
And
look
so
like the test really
we see
well.
them
And
here as well, don't we? We have, I think I tend to see that, I guess, in a Pacifica or Maori population might have more. And I measure that then, I'm sort of, for the listeners, in external, internal, total range is what I would compare it in the opposite shoulder, because there might be less guarding, and then see what is in that side. And these players definitely have traumatic instability, but there is an element of that increased range. And so then, based on some of your work, I've been trying to restore that range, that strength, all the way through their range. That's my sense there. What is yours? What do you
and I
think?
agree, but I almost think it, because obviously when you're doing research, it has to be very standardized. So they're
Yes,
they're 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 measured from a 90/60 because from pilot testing, that's what
yes,
most male athletes will have that, unless they've a lot of pathology. And I would always argue you can get it back if you bring them back enough, and you can access that corner, like unless they have true pathology in there and there's big changes to the posterior corner or like real severe, which you do sometimes get, or the other caveat there is if the rotator cuff is affected, obviously that's a different ball game, a completely different ball game. But yeah, so we have this kind of, but yeah, certainly for the hypermobile athletes, I do think we need to be assessing. And I also think,
mm,
and probably because I know Ben's, because I remember him asking me at the time around the role of those tests versus these, and there's so many things, you can only pick so many things.
yes, yes,
And rotational torque was quite developed at the time. It was kind of gold standard, so you need something to
yes,
compare your newer stuff to. That's why we had
yes,
that there. And plus, I always looked at it manually. Like I'll always look at that manually, in every
yeah,
single. So, and actively and in lots of different ways. So I absolutely find it useful. But yeah, I think with the hypermobility, and it's whether we need to, yeah, and even how I rehab them, often I'll take my ordinary contact athlete through all the early rehab stuff, then through that strength block, your normal push and
mm,
pull horizontal stuff, and then into more chaotic and
mm,
RFD stuff. But these guys, I tend to have another like layer along that, and that's often things
okay,
like your pikes, your handstands, your ring work
yeah,
that they're beginning to access because there's so much more range. And they are the ones you get stung by because you're like, they're testing really well, and they go on and have a freaking event, and you're like, okay, is there? So I'm having to really try and I'm sure and this would be nice so that we can talk further on. What are your thoughts on them, and how do we bulletproof the hypermobile contact athlete? I don't know.
yeah. They're
Um,
challenging, aren't they?
Incredibly difficult. Yeah, yeah. And
Yes.
there's lots of variations, and I think the approach I've probably changed my approach a little bit with those in terms of,
Mm.
yeah, really, really thinking about all of yeah. And it'd be interesting if there, and I don't know actually, is the mechanism of injury different or, yeah, yeah.
It's so interesting, isn't it? I had a really interesting chat with Anne Cools recently about, the limitations in the research and what we see in clinical practice and the discrepancies, isn't it? Because the research needs for the sake of the research needs to be gold standard. It needs to be
Yeah.
very methodical and systematic. But then patients present that don't necessarily fit with that inclusion criteria. And so how do we extrapolate that research into those populations, isn't it? That's the challenge for clinicians, isn't it? Because that's
Yeah, it
the
is. Yeah. It's
mm,
really difficult. And even and I remember having a chat with one of the surgeons and she's like, you know, he's tested really well on the testing and he's gone back and had another event like he did. And I was like, I know, I don't think these tests are good enough for the hypermobile shoulder, the
yeah,
contact athlete.
yeah,
And these were traumatic events,
yes,
and huge structural changes like ladder J's and stuff. But then
yes,
it's dislocating over reoccurring over the ladder
yes,
J. And I'm
yes,
starting to see a number of those of
yes,
reoccurrence over ladder J's, or I've
yes,
had one that reoccurred under the ladder J and took off a
yeah,
huge chunk of very young player at international level, and it's insane. Um,
yeah,
and it's
yeah,
like the team saying they wanted to really like. I was like, "Are you insane? This is so hard," and and it's even just player health because in my opinion, those you have to absolutely optimize all your biomechanical markers before you
yeah,
send them back. Massive injury and just even the joint changes, but then the demands of the sport are so high, and the
yes,
teams often obviously are under a lot of pressure and they have different demands, haven't they? So there's a lot to there's a lot at play, isn't there, around all of those kind of
mm,
decisions, and the return to
mm,
sport decision making can be very
tough,
difficult, but I
tough,
probably believe very strongly in getting your basics, when
yeah,
they're so at risk for these players
yeah,
that at least you have your basics covered, like your
yes.
rotational.
Yes, and so at least then you can, and maybe, I mean, because there's a number of different factors here, But maybe that covers maybe 80%, or I'm just plucking a number,
Yeah,
but
well,
maybe,
yeah. It's the
those
stuff you can
basics.
change, isn't it? It's the
Yeah,
stuff you can. And we know you can get them. I think that's the nice thing about the test now. We are more answerable. So whether it is you're looking
yeah,
at rotation strength or handheld anemometer or the force plate, so whatever you decide to do, if you know you're doing them reliably and you know what the norm is, because not
yeah,
just comparing against the other arm, because that's the other thing we found
yeah,
is there was the other arm wasn't to where it should be compared to the norms, so there's
yes,
obviously a
yes,
deconditioning element, particularly in the early on stages, so it's all of those things, but at least because I know you were saying we feel like sometimes we don't have it right. I don't know if we ever will, but like at least everybody's having conversations about it now in the upper limb, aren't
yeah.
they? It's a
And the
real
space
topic
is
of
moving
conversation.
forward. Yeah, and your
It
work
is,
is
and it's moving
contributing
in
to moving that
and moving in
forward.
lots of different directions, isn't it? Which again, I think is normal because the sports are so different.
Yeah,
And again, even different to the lower limb because a lot of the sports, the change of direction stuff can be, that can carry across through a lot of sports, whereas in the upper limb, the
yeah,
throwing shoulder is very different to the contact athlete shoulder. It's very
yeah,
different,
yeah.
so, I think I think there'll always be different outcome measures there,
Mm,
absolutely.
mm. Can we
And the
dig
same with the
into,
female athlete, I think, as
yeah,
well, is the other big thing. And as I said, I purely looked at contact male athletes because, like, for every 100, in our clinic anyway, for every 100 male stabs, it was significantly smaller, 5 or 10 female stabs. So it
mhm.
was it was definitely and their mechanism is different as well, isn't it? But then there's some really good people doing some great work now in the female cohort as well, which is so
Do you have
important.
a sense that they're different? So in New Zealand, the female, we found in our prospective cohort study that sex isn't a risk factor in New Zealand. There is
Ah,
a predominance. There's more males, but the difference wasn't significant because I think some of the females in New Zealand are playing rugby and falling off their mountain bike and snowboarding. Do you have a sense in your population whether the males are different than the females? What that
yeah.
what that looks like? There's
That's really interesting because I remember I even just justifying your research question, I had to justify obviously while I'm looking
Yeah.
at male versus female. So I had to pull out all the literature of what was out there. And even, from what I recall now, and I might stand corrected because it might have been updated, but the mechanism of injury for the males are very much contact with another player versus contact, say, with the
Mhm.
ball. For a female, it was
Okay.
much
Yes.
more contact with an object versus contact with a player. That was one of the
Yes.
big things. The amount of stabilizations was quite different. So yeah, and I know some really great people doing qualitative studies now on the female population, and
Right.
even the other big variance is here. Like, I don't know about you guys, but the male, say, rugby players are professional. Often rugby is their only job, or
Yes.
like they get paid for it versus the females. There's huge
Yes.
differences there. And you could be rehabbing, one of the international female players and they've worked with the army and they're coming in after
Yes.
48-hour shift and are training in the morning. That's like
Mhm.
totally different. There's still huge, obviously, discrepancies, isn't there, in different
Yes.
sports? So I think there's so many different variables.
Do you
Yeah,
think that
with
we could extrapolate your findings from your PhD into that that population in terms of the loss of
don't
strength
think
through
so.
range, or you think
Yeah.
we need to do that again in a female
Yeah,
population?
I
What do
think
you
so.
think?
Yeah, and I think maybe even the tests might be different.
Yes.
Yeah, because even yeah, I think taken into account, and I think that's, and there are people looking into that now in the female
Mm,
population as well.
mm.
Um,
We
but
found that
yeah,
when we were looking at those, because in a population of US college people, we looked at those push-up claps, and the number of females that could actually do one push-up
oh
clap
yeah.
was quite limited compared to the number of males. It's just different strength to body weight, isn't it?
It
So,
is, it is, it
yeah,
is, it is. Yeah, and even like, yeah, it is. And we started then, trying to develop a force plate at an angle on
yes,
the rack.
okay,
Yeah, and there was a lot of noise, so it was hard to get it reliable. Yeah,
yes,
so that we could use it a little bit more in the female population, and particularly it depends on what stage they are of the rehab as well. But like
yeah,
as I said, because certainly this side of the world, the expectations are very high around returning to sport. And the
mm,
nice thing with the tests, actually, they seem to have slowed the surgeons down. Not the surgeons; they
yeah,
were probably never the ones pushing it, but even you know, in a nice way. Like I find with a young contact athlete, I actually love when they don't score well because I don't want
yes,
them back as quick because the
yes,
younger they are, the higher the risk. So the 14, 15-year-olds, I'm absolutely looking for perfection on those. I use the scores as
it's a
as a
way to mitigate
yeah, and
that.
particularly because a lot of them mightn't have the resistance training, so it's quite hard to score well in some of the performance tests. And the more history you have of
Mm.
resistance training, the better you're going to score. There's all of
Yes, and
those
they're
elements.
younger.
Yeah, and if
Yes.
you haven't, you can't technically execute. Like there's so many elements, obviously, that affect it. So often you're building all of these nice capabilities with them that they weren't
Mm,
familiar with them. But yeah, I
mm.
think yeah, if anything, and it's nice to have a few factors to be answerable to, isn't it?
Yes, it's so nice. Like, because my next question for you is, how has your work then changed your clinical practice? And now I can see that the metrics you're producing really justifying for some of these younger athletes that they're not quite ready, and that
Yeah,
actually
yeah.
and you're looking for exactly what do you, so for the clinicians that do have force plates in their clinic, what are you looking for in those younger athletes, specifically with the metrics?
So we look at a couple of different things. So what we look at jump height, and then we look at impulse is probably the most meaningful thing compared to say just peak force. So that's force
Yes.
applied by time. So it gives you a bit more bang for your buck. You can not just because often you'll find, say particularly on a back land, they could land very heavily, so they're landing peak torque could be quite high, but that's not necessarily a good thing. So it gives you more information how the force is applied over time.
Mm,
So you've got two
mhm.
variables there that to take into consideration, and that can affect how you plan or train them. Um,
Yes.
So we find things like eccentric deceleration impulse and concentric impulse quite useful. And jump heights, we've got some set markers now. Because we're in a lab setting, we have a 3D marker at C7, so we can be very accurate in how we record jump height. I know some of the other ways of calculating jump height isn't as reliable. So again, you just take these things into consideration, don't you?
Mm.
Um, and again, having a bit of a baseline of what's norm out there.
Yes.
So yeah, so we look at, and then the other big you can look at interlimb asymmetry. So we know, say in the uninjured athlete, the interlimb asymmetry, the absolute interlimb asymmetry is between 4 and 10% in these variables. So it is,
Right.
yeah, so you can have that 10% marker, I think
Mhm.
quite reliably as a, okay, if they're, and you'll get some of them that are 30, 40, 50% down,
Yes.
huge
Yes.
variance. They just aren't able to. And as I always say, they are tough tests. So it's quite hard to score well in them. So yeah, so having so you can certainly use your interlimb asymmetry and any of your valve force plates that will
Mm.
output that for you anyway. The only
Mm.
thing is they often put it as a counter movement jump versus it depends how it's programmed as a counter movement. Yeah, yeah. And
Yes.
then at the time
And
the
so the
jump height.
normative data for clinicians, you've published normative data in this space. They could look at
Yeah.
the healthy
Yeah,
population that you
yeah,
compared
yeah,
with,
yeah,
couldn't they?
yeah, yeah. As I said, the only thing that'll be different will be how you're calculating jump height because we have a
Yes.
C7 marker just for
Yes.
accuracy, obviously, and reliability.
Yes.
So it depends. But things like interlimb asymmetry you can use as a
Yeah.
yeah as a marker. And then that's a good, that's a decent variable because there's definitely asymmetries there.
Yeah.
And then with the isokinetic strength, probably the big thing is again, we often hear 10 to 15% difference, don't we? The only where there is, even in the norm group, there is kind of more variability is in that inner range external
Mm.
rotation. So it's up to about 22% difference there in our
Okay.
uninjured population. And I think that's purely just because the amount of torque you're producing there is lower, obviously. And
Yes.
then in
Yes.
terms of percentage body weight, if you're getting around 20% body weight in that range, that's pretty good.
Yes.
So, if you're getting 7% body weight versus 12% body weight, the asymmetry is going to look bigger, isn't it? So
Mm.
yeah, just a bit of a caveat around those ranges, because
Yeah.
the
Okay.
it's a little bit lower. Yeah, yeah. But again, it's just knowing the norms, I think, of whatever you're using.
Yeah. Yeah.
And keep it simple. I don't know if you agree as well, but like make sure you're reliable, keep it simple and keep a few key things. And if you're getting that right, that's really good, isn't it? That's
Yes.
loads better, whatever you do, and I think is
It's like we were chatting
a
before, isn't it?
concerted
It's about
effort.
doing the basics well. If you do the
Yeah,
basics well, like sometimes I was saying, I think some of the stuff I do is like, oh my God, this is so boring when I could be doing really fancy stuff. But actually, I believe that that's the bit that makes the difference, you
of
know?
course.
So,
Can't skip
um,
it. And
yeah,
and and, and I'm sure like anytime I'm asked to see somebody struggling, it's the small stuff. I'm always
yes,
doing big. It's the small stuff. They're missing the small stuff, and you just cannot access. Like when you're really missing that inner range external rotation, you're suddenly knocked out overhead stuff, end range
yeah,
flexion. So,
yeah,
they usually obviously correlate. So any of your dynamic stuff up there, or even your overhead press, because they all love, or even your pull-up position, your end of your pull-up
yes,
position. All of those are suddenly painful, and then their envelope of function starts dropping, doesn't it? Because they're not
yes,
in the yeah, yeah. And there's so many lovely ways. I think there's lots of bridging. I agree with you. For me, it is the getting the small stuff really good and get that really good early on. That the rest of the stuff you can
mm,
start feeding in all your strength parameters to then
mm,
work into deceleration, RFD, more explosive stuff. And I agree with Ben obviously on that. They are parameters you do need to chase.
yes,
Um, But it is, and generally with some structure, the strength and conditioning coaches are great. Like, I'll often
Yeah.
get them in. I'm like, have a look at this program. Why isn't he hitting the targets? What am I missing? And they're like, you could have buffered the volume a bit more in there with some triceps and biceps stuff for some push work.
Okay.
Being quite
Yes.
creative in how you can buffer volume when the
Yes.
shoulder isn't quite ready for it. So they can be, or just how you program your more compound lifts in your overall program. So they have so many amazing ideas on how to, how to kind of program all of that. So that would be my other advice. And never be afraid to ask. I'll
Mm.
often, I often work closely with the strength and conditioning coaches anyway, but having another pair of eyes on it, because you can get lost a little bit, can't you? Sometimes there's
Yeah.
like so much programming. And I always think with the staves, we have such a short period of time. The ACLs of like a year, and we're like
Mm.
such a
That's
short
part of the
period.
problem, isn't it? I think, like we know, like
Really
some of that
difficult.
fear stuff that I've done, we've compared that with the ACLs, and we see that these players going back to play much shorter time frames, like you say, but much higher levels of fear than in an ACL population, which I think
Mm,
is part of the story as well that we need to try and understand.
yes.
Where do you think the
No,
gaps are? Adele, where do you
yeah.
think we're going here? What's the future for return to sport testing? Where do
Yeah, it's such a big question, isn't it? Do you know
Yeah.
what I think? And I remember I was asked to do a presentation recently on, um, the title was, return to rugby. Where are we, following shoulder injury or shoulder stabilization, and where are we going with it? And I think it's just so multifactorial. Obviously, the objective testing's one part, isn't it? But it's huge things
Mm,
like diversity in sport, all these other risk
mm,
factors, you
yeah.
know, um, age, like this thing of playing even a year out of your age, or here, like, all of these things are hugely more controllable. And then it's the technical element. You go in on the wrong foot and a long arm and you're only 50. It's all of these things. So
Mm,
I think there's a huge thing around diversity in sport, and the importance of that, and probably being categorized in your age better, and the risk of playing out of your age, for like,
yeah.
if you're on a career potential to be a professional athlete, and you at 15 you dislocate and you could have another one, like, that's really devastating, isn't it?
Mm,
And potentially career ending. So I think there's huge scope around all of that stuff. And as much as the objective things, as I said, all you ever try and do is, be as answerable as you can to it.
yeah.
I don't know the answers around what's the right testing, or what, what's not. And I think there's so much diversity in sport and all of those, isn't there?
Mm,
Um, but yeah, I think it's probably quite multifactorial on yeah, and
yeah.
all of those other kind of factors to have a think
Yeah.
about, um, rather than just all the objective testing, and where the surgeons are going with all
Yes.
of their, massively influences as well on the types of surgical decisions they're making. And
Yes.
how they often, our guys there, well, some of our surgeons will use lattice as the first port of call, because the risk is so
Hmm.
high for the contact athlete, even if the bony pathology isn't extensive, or
Yeah.
doesn't necessarily fit your criteria, because they really struggle as well.
Mm.
They
Yeah,
really
it's
struggle
trying
with their
to
decision making.
Yeah,
Yeah,
it's challenging, isn't it? They're in the same
yeah,
situation that we're in. We're trying to
they are.
answer the same problems for their athletes. So, yeah,
Yeah, yeah.
yeah,
And the bone loss. And then this, like, what's it going to be like 10, 15, 20 years down the line? Although
yes,
obviously athletes, that's far from their mind, isn't it?
yes, it
Um,
seems to be. Hey,
yeah,
Adele,
for
it's been
sure.
super great chatting with you today.
Oh,
It's
thank you
been,
so much.
I appreciate all the work that you're doing in this space. It's just fantastic.
And thanks
Yeah.
so much for today.
Oh, it's been
No, and it's
fun.
been, yeah, and great to connect. Thank you.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. Don't forget, you can follow me on my social media for some more up-to-date content. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.